All right. Can everybody see that? Yes? We good again? Sounds good. All right. So today is a huge one. God, this is basically a third of BAB. Um, at least it's probably more than a third of the questions you're going to get on any standardized exam. Um, Depression, anxiety, they usually hammer in the drugs, and differentiating between a lot of the there's like a lot of like nuances between the types of anxiety and the types of depression, but I'll go over those. But the really big one here is spinal tracts and brainstem. And yeah, each lesion, each tumor type, each type of stroke, each everything kind of has its own little excerpt, but it is absolutely worthless to learn it that way. And you should just learn all of the tracts and then piece it together as you answer the question. And I'll show you what I mean when we get to the end. And I'm going to give you guys a really easy way to like draw everything out in like 2 or 3 minutes, like during that like instruction period at the beginning of the exam, when like the timer started, but like it's not the real timer, and you can like make notes on your sheet. And then you can just look at it while you're answering the questions, and you're never ever ever going to miss a brainstem question, and you're never ever ever going to miss a spinal tract question. But before we get to that, we're going to have to go through the psych stuff. So as always, if I say something wrong, sometimes I get dyslexic with my words. So if I misspeak, please be like, "Hey, John, you're being an idiot," and I will try to correct myself. All right. So with depressive disorders, with basically all of these psych disorders moving forward. So depressive disorders, anxiety disorders, trauma disorders, timing is everything. So many times, the only difference between two of the questions two of the answers in a question is timing. Either when did the patient's symptoms start? When was the precipitating event? Has there been periods of downtime in between presentations of symptoms? Right? And then it'll be like there'll be have to like some check mark criteria, right? So with depression, they say SIGI caps, right? And then the other big thing is, does this affect their day to day? If somebody's really sad, if somebody's really stressed, if somebody's going through a tough time, but the question specifically tells you, oh, but they're functioning fine at work, they're functioning fine at school, you're probably not putting a disorder for the answer. All right, so again, this chart, I stole this right out of the step book. This is so useful. You need to know the timing of these things. Does it start after a week? Does it count after a month? Does it count after 6 months? Most of the things I'm going to tell you right now are you can't count this as a disorder until it's been going on for 6 months. So it's almost easier just to remember the ones that don't fit that criteria, as opposed to like trying to remember the specific time for each of them. But so major depressive disorder. So they say SIGI caps, right? You lose sleep disturbances, no interest in things, you feel guilty or worthless, low energy, low concentration, appetite and weight changes, any type of like motor dysfunction or suicidal ideation. I'm gonna be honest with you. If you're saying major depressive disorder on a question stem, or if they want you to say it, you don't have to sit there and count these. There's going to be so many different avenues that the patient is wrong. It'll say like, oh, well, I'm not eating anymore and I don't like to do this, even though I used to like to do this, and I can't concentrate at work, or I'm having a hard time concentrating at school. They will throw so many symptoms at you. I've never seen them throw like 4 symptoms and then it just been like, oh, well, technically it's not major depressive disorder. It will be just full of symptoms. And again, has to affect their daily life. Another thing that they like to kind of get you on is kids can't act depressed. And basically, when they say that, for a lot of these criteria, like kids can still obviously be depressed, but you can't count like a depressed mood, like a depressed presentation, as one of the criteria for any of the depressive disorders, because by and large, kids are considered to not have very good emotional regulation, and they tend to like act out with their feelings, right? So you can't count that as like a diagnosis criteria. The other thing is, when you're going to treat depression, all the depressive disorders, you have to rule out bipolar disorder. And the reason being, because if you have someone's bipolar, you diagnose them as like unipolar, just depressive disorder, and you treat the depression, you'll send them into a manic episode. And that's like a big thing that they ask about with like some of the drugs. It'll be like, oh, Patient came in, was clearly depressed. You started them on an SSRI, and now they're talking to God, like basically what happened. And the answer will be like, well, you failed to screen for bipolar disorder before. And the other thing that you guys will learn about later, you can't diagnose someone with Alzheimer's until you rule out depression, because in the elderly, when they get depressed, this happens a lot when like they lose a significant other, and then there's just one of them left. Their memory goes, they just start to lose it mentally. And then if you treat the depression, they come back completely to normal. So there's a couple different forms, but the PHQ-9 is the one that like we'll be using mostly. So this is basically the tool that you use to screen for depression in like the emergency room or in like a PCP's office. If you're using anything more in depth than the PHQ-9, you're probably in a psych office. So that's like they call the Beck depression inventory, which gets scored up to like 63. This is out of 27. This is really easy to fill out. Every Medicare wellness exam, the patient has to fill out a PHQ-9. It's just really easy to have them do this. I don't recommend you ever fill this out yourself, especially not during medical school, because you will realize that you are moderately to severely depressed. And that's not good for study habits. So other types of depression that they'd like to distinguish between, really the only one is persistent depressive disorder, which is also called dysthymia, not to be confused with cyclothymia, which you'll learn about when you go through the bipolar disorders. The thing that I believe they tried to hammer in on block exams, but not on like a form or anything, is the early onset versus late onset. And the only difference there is if it sets in before or after the age of 21. I've never seen like STEP or UWorld care about this. I got an AMBOSS question about it once, but I do think they asked about it on one of our block exams, or at least maybe they fished out a UWorld question. It was one of the quizzes. Just know that for dysthymia, early onsets before 21, late onsets after 21. And basically dysthymia, it's like depression light. It's like 2 symptoms, goes on forever. You're always experiencing the symptoms, like 2 of the SIGI caps, right? You always have the symptoms more often than not. And it never gets better for longer than 2 months. And this is one of the ones that it has to last at least 2 years when you're in kids. MDD with seasonal depression or pattern. This is like sadness, right? Seasonal affectiveness disorder. I think we've all heard of this. You know, in like Alaska, it's the sun doesn't shine for 24 hours a day sometimes. You treat this with light therapy. This is vitamin D deficiency adjacent. I've seen questions on this, but like it's not super high yield. And then MDD with psychotic features. You're gonna want to put this as an answer a lot. It's almost never the answer. This is pretty much never the answer. And when you go through the schizoaffective disorders, you're gonna see basically why. But this is usually bait. And then depression with atypical features. This is almost also never going to be the answer. I would put this as an absolute last option if I've 100% ruled everything out. And it's just, so the problem with a lot of the psych disorders, and also the problem with a lot of the treatments for them, is psych disorders are all made up, and treatments for psych disorders are very nuanced, and people in the field generally can't agree like what the actual, this is actually better than this is actually better than this. So you will learn, for the purposes of STEP, these are what you always reach for first, these are what you always reach for second, these are what you always reach for third. But like in practice and when you're on rotations, you're probably going to say something and psych's going to look at you and be like, well, yeah, you should do that, but technically this works better, or something like that. So you're just going for like broad patterns here. I've seen this asked about more than I thought I would, the peripartum mood disturbances. Ironically enough, I've actually seen the premenstrual dysphoric disorder asked about more than I've seen postpartum depression, which is MDD with peripartum onset. Never seen a question about postpartum psychosis. Have also seen a question about postpartum blues, but generally what this is postpartum blues, 2 weeks. You're allowed to be sad for 2 weeks after having a kid. If you're sad for more than 2 weeks, you get depression. You're labeled with postpartum depression. Treatment, as you'll see, for basically everything, CBT and SSRIs. I'm going to say it 1,000 times. I'm going to get sick of saying it. You're going to get sick of hearing me say it. CBT and SSRIs treats almost all of these disorders. For the premenstrual dysphoric disorder, the important thing is that you get a lot of depression symptoms 1 week before onset of menses. But more important than that, they have to completely resolve. The symptoms have to completely resolve. within a week of post-menses. Not like, oh, well, it got a lot better, but I'm still kind of sad. I still can't focus at work. No, the question will tell you that the symptoms have completely resolved within a week of post-menses. And it has to occur in most of the menstrual cycles. I've never seen, but they're not going to ask you a question that's like, oh, well, it only occurs in, 5 of the menstrual cycles in the 12 months of the year, so it's not really premenstrual dysphoric disorder. No, they're not going to do that to you. Just look for the resolution of symptoms within 1 week of post-menses. Grief, this is another big one. Almost every time they ask about grief, it's in kids. You're allowed to be sad for 1 year after your spouse dies. If you're sad for 366 days, you're depressed. With children, the thing that they hit a lot is they'll emphasize that the children are talking to their dead relatives. This is perfectly normal in kids who have suffered loss. This is whether they see their dead relatives, whether they hear their dead relatives, whether they think they're doing things with their dead relatives, completely normal behavior. And the answer will usually just be normal behavior. As far as suicide screening and risk factors, usually it'll come up in an ethics question where the patient will be like super depressed and it'll ask you what you should do next, or it'll be a physician response and the response needs to include some type of suicide screening. As far as risk factors go, previous attempt is always the highest risk. However, if the question asks you what you can do to most decrease the patient's risk of a successful attempt, the answer will basically always be remove access to firearms. But like they'll ask you a question, it'll seem like it's such an obvious answer. The answer is take guns out of the home. If they ask you specifically, and this is how they usually do ask the question in a lot of things, wink, wink, it will say the greatest to reduce the risk of a successful suicide attempt, it is always going to be remove access to firearms in the home. And the reason is this is one of the big ones that we can like do something about, right? As far as risk factors go, women commit or make attempts 3 times more than men. Men die 4 times more than women from suicide, mostly because men choose violent means like shootings, like self-shootings, whereas women will typically try like drug overdoses. Usually it's Tylenol. Also, the statistics kind of count repeat events as far as like isolated incidences. So someone who overdoses on Tylenol and then immediately calls the hospital and then goes and gets their stomach pumped and whatnot is likely to try again, because the number one risk factor for a suicide attempt is a previous attempt. The mnemonic for this is literally sad persons. I mean, but yeah, they're usually going to ask you, it's going to be about a previous attempt or about removing access to firearms in the home. I've seen like one question where they get like really granular and like, what is their greatest risk for suicide? And I'm pretty sure it was just a previous attempt. But it's all other things that you would think of. The other thing too is protective factors, controlling comorbidities. So like controlling addiction is usually what they're talking about here. Having a good support system at home, because people can't really work through these things by themselves. Being religious is wildly protective against suicide, which I guess makes sense. And then if somebody has rationalized problem-solving skills, they're usually going to be able to, you can cognitively discuss with them so they can think their way out of the hopeless situation that they're in. So if there's also like ever a physician response question, you want to ask them specifically if they have a plan. Because do you have a plan is really the only question that weeds out, does this person want to die? Does this person not want to live anymore? Does this person actively want to kill themselves, right? Because there's the gaps between those 3 things, even though they sound like the same question, are miles when it comes to psych care. As far as violence, anyone who makes a specific threat, it's the highest predictor for a violent attack. This counts against family members, friends, lovers, physicians, and usually what they're going to want you to do is either it's just like some BS physician response question, or they're going to have somebody who is, you're going to think it's an overdose question. Somebody comes in high on like PCP or something, and he's very combative. And the police officer is like basically harassing the dude, right? And they're like, oh, if you don't behave, we're going to lock you up and throw you in jail. No, the answer is you remove the agitation, right? You tell the police officer to hit the road. We'll watch and we'll call you when we're done. You remove as much stimulation as you can from any form. Don't try to be combative. These always come up in, whenever this comes up, it's always in like a physician response question. The rest of it's common sense. But yeah, the specific threats, are the number one predictor. And as physicians, we have a duty to warn. Sometimes they ask this in ethics questions. You need to try to identify the person, and I mean like as specifically as possible. So for example, if someone says they're gonna like they want to kill their ex, right? You need to try to find out like their name, and if you can try to get like a number or an address. Obviously that's ridiculous, right? Like I don't know how often this is gonna work. But if for as portion like on the test, you want to find a specific name and number and then notify the police and then also warn that person. I guess sometimes it'll be next of kin or it'll be like somebody on their medical form and you can get the information. But potentially involuntary hospitalization, they say you can do this. This varies state by state. This is basically impossible to do. You need a court order, at least in Michigan, to hold someone for more than 48 hours. Even if you have a patient that tells you, looks you dead in the eyes and says they're going to go home and drown both of their children, you can't psych hold somebody for more than 48 hours without a court order. And then it's up to 60 days and it's up to 120 days. There's like Kevin's Law is one, and there's a bunch of other ones. This is state by state, so they almost never ask questions about it. Okay, so for treatment, I like to call depression treatment SSRIs and ADRs. The main reason is because you're always going to treat with an SSRI. And if they're asking you about something that's not an SSRI, it's because there's an adverse drug reaction. Yeah, I mean, that's really as simple as it is. MAO inhibitors, they like to harp on a lot for the adverse drug reactions, and tricyclics. I don't even know why they use them anymore in most cases because of how bad the side effect profile is. And then sometimes they'll ask you about like alternative treatments. Generally, step one isn't really supposed to ask us about like passive treatments or like what's the next best option. However, there are some cases where they do like to ask those questions, and the psych drugs are one of the topics where they'll generally say like, oh, what would be the best option to treat, right? CBT and SSRIs, or it'll say the patient has had this side effect, what would be the next best drug? And we'll go through that in a minute. I use all of Dr. Paul's flowcharts because, I mean, quite honestly, they're the best visual representation of most of the drugs in any chapter I've ever seen, better than any of the layouts in like the step books, or I don't know, unless you're like a sketchy person. Like these are just so good. So I'll always use flowcharts. I threw this slide in here because I'm a visual learner. So if you're a visual learner, this will help you remember a lot. Go through this as you're doing questions and as we're talking about the drugs. But you can see here, like tricyclics, they hit everything, right? Serotonin, noradrenaline, histamine, acetylcholine. This is why they have really nasty effects, because you have histaminic and cholinergic effects with the tricyclics. But this is just a good slide to like take. I would take your own personal notes on this slide. All right, so SSRIs. It's like the serotonin reuptake inhibitors. More serotonin in the synaptic cleft. It's basically like having more serotonin in your body, right? 99% of the time, if the patient is not on anything, if they have never had a drug before, they want you to start them on an SSRI. Pick whichever drug is an SSRI. That is your go-to safe answer. Another thing they like to, also, I know I put the stars in, right? Like you absolutely have to know this. Unfortunately, with the psych drugs, because they ask you such specific questions, there is a lot of things like, hey man, you just got to know this, right? So SSRI is always a safe bet. This is a big one they like to ask about. It takes 4 to 8 weeks for SSRIs to take effect. So sometimes patient will come in, you'll start them on like fluoxetine or something, and then it'll say they came in a month and they're still depressed, and it'll be like, what property of the drug is causing the problem? And it'll be like slow to act, or not enough time to build up systemic concentrations of the drug, right? The number one side effect they ask about with SSRIs is sexual dysfunction. All right, I put this picture in here, right? Guy's real embarrassed. His wife's real frustrated. Sexual dysfunction is asked about so much. Decreased libido, inability to obtain an erection and keep an erection. This is like the number one ADR for SSRIs. You absolutely 1000% need to know this. Rarely you can get serotonin syndrome, or like I was saying earlier, if you diagnose someone with depression and you give them an SSRI, but you don't rule out bipolar disorder, you can get a manic episode. There are some questions on that, which is kind of the only other ADR that they really talk about with SSRIs. I've never seen a question that's just like, oh, they're under an SSRI, now they have serotonin syndrome. Fluoxetine is the big one. So is sertraline. I would know the names of these two, but it's usually going to be one of these that they're asking about, fluoxetine or sertraline. All right, SNRIs. right? Serotonin and norepinephrine reuptake inhibitor. So this blocks norepinephrine and serotonin reuptake. It works more quickly and it's stronger. It also causes less sexual side effects, right? They're much happier couple. Disclaimer, you would think that SSRI causing sexual side effects, you take them off the SSRI and you start them on an SNRI, right? Because it's like the next in line, very similar mechanism of action, but they have less sexual side effects. That is not correct. It still has sexual side effects. It just has less of them. So if you're taking somebody off of an SSRI and starting them on another drug, you don't start them on an SSRI. You usually start them on Wellbutrin, but we'll talk about that in a second. Duloxetine is basically the only SNRI that they ask about as far as treatment for like just straight up depression. Duloxetine is pretty much going to be the answer. It can also be used for neuropathy, like peripheral neuropathy, usually diabetic neuropathy, usually in conjunction with gabapentin or Neurontin, same drug, or used for fibromyalgia pain. All right. This is one of the first stupid memory tools. I don't know how many stupid memory tools I've given you guys yet, but if anyone's watched the sketchy for these, the venlafaxine, the fax machine, right? Okay, listen. I don't know how many fans there are of 90s hip hop. But if you're down with OPP, use Viloxazine, venlafaxine, however you say it, right? It's stupid, right? If anybody knows what this song's about, it would make sense that this is the one that has less sexual side effects and they're down with OPP. That stands for OCD, PTSD, and panic disorder. Venlafaxine is used to treat like the weird psych disorders that isn't used to treat with an SSRI, right? This is how I remember this. I know it's stupid, but hopefully it gets you a question around the test. Tricyclics. The only tricyclic they ever really ask about is amitriptyline or nortriptyline, but it's the same. They're basically the same drug. They say triptyline. You're never going to miss it. So these block the reuptake of norepinephrine and serotonin, but they also are acetylcholine and histamine agonists. So they have anticholinergic and antihistaminic effects, right? So this is your hot as a hair, dry as a bone, red as a beet, blind as a bat, mad as a hatter, fast as a fiddle, full as a flask, right? There's also can't see, can't pee, can't spit, can't, the rest of it. But yeah, the reason why they also ask about amitriptyline a lot is because it causes prolonged QT intervals, right? Everything that causes prolonged QT intervals, you should think torsades. You should think sodium problems. How do we fix torsades with magnesium? And if you see down here, they use the tri-Cs tricyclic. This is from the step book: convulsions, coma, cardiotoxicity, and arrhythmia. The arrhythmia is due to sodium channel inhibition. So how do you treat it? You treat it with sodium bicarb. I've straight seen this as a question like 4 times. Like, they want you to know the patient's on a tricyclic. They literally ask what you give to reverse. A lot of people will look at it and be like, oh, this is probably serotonin syndrome. No, the answer is you give bicarb. They're on a tricyclic. The other thing that tricyclics can be used for, they're not really used for migraines. You'll learn about better migraine drugs later. I've never seen a question asked about the pain or the migraine aspect of this. But treating enuresis, because they're anticholinergic, right? So you have M3 antagonism, decreases the detrusal muscle activity. You don't urinate as much in your sleep. So it's used to treat bedwetting, essentially. And then the number one like benign side effect is orthostatic hypotension. So a lot of times they'll talk about like a patient comes in, patient's depressed, they're starting a new med, they don't know what it is, but they get dizzy when they stand up. It's a tricyclic. The answer is amitriptyline or nortriptyline. And this is due to the alpha adrenergic blockade. Monoamine oxidase inhibitors. Okay, so monoamines, right? You got like dopamine, all of them: dopamine, norepinephrine, epinephrine, serotonin. This increases their half-life essentially. There's 2 kinds. There's MAOAs and there's MAOBs. So MAOAs, monoamine oxidases A, break down serotonin and norepinephrine. Monoamine oxidase B breaks down just dopamine. So MAOA inhibitors treat depression, increase serotonin, increase norepinephrine. MAOB inhibitors treat Parkinson's. You'll learn about this later. Selagiline, anytime they ask about this, it's in the context of Parkinson's disease. Transcyclamine is overwhelmingly the MAOA they ask about the most. And then these 2, I don't know, maybe I've seen a question about each of them. Just be aware that these are MIOAs. There's nothing specific about them aside that. Actually, phenelzine they ask about. They use phenelzine as like the example. So MAOAs have like all the same side effects as TCAs basically, except because these are monoamine oxidase inhibitors, they have drug interactions with basically anything even remotely psych adjacent. So if somebody's on 2 drugs at once and one of them, and like all of a sudden they have like serotonin syndrome, or they have mania, or something, or like they're like not quite a pheochromocytoma, but like you have similar symptoms, right? You're super tachycardic, your blood pressure's through the roof. The answer is probably the MAOA is probably the problem. They want you to pick the MAOA. They don't really use these because of that. The only time it's really used is for atypical depression, which we talked about earlier, is kind of the catch-all for we got nothing. And then resistant depression, when somebody hasn't like responded well to like literally any other drugs, they'll reach for an MAOA. Because of what I just mentioned about how they're just nasty interacting with everything, you have to wait 2 weeks, stop someone on whatever drug they're on for 2 weeks before switching them to an MAOA, MAOI. Otherwise, you get serotonin syndrome. The other thing, and this is really the other thing they ask you about a ton, the cheese reaction, right, or the tyramine. So tyramine is a norepinephrine precursor, but it's also a pressor. So if you're on MAOI and you eat something that has a bunch of tyramine in it, which is basically anything you'd find on a charcuterie board or drink while eating a charcuterie board, right? Cheese, smoked meats, beer and wine. You end up with hypertension, tachycardia, stroke, seizures, and or death. They love the cheese reaction. It's literally called the cheese reaction or tyramine crisis. As far as atypical antidepressants goes, the one they ask about the most, let me rephrase that. The one that you are going to put as an answer the most is bupropion. This is Wellbutrin. I predict that by the time we're all attending, this will be fighting SSRIs for the #1 reached for antidepressant. It says on here discontinued by manufacturer. That is absolutely not true. 1000% this isn't true. This is Wellbutrin. They use this for smoking cessation. They use this for depression. They use this for adult ADHD. This is like a one-all catch-all for any psych problems anybody roughly our age has. Wellbutrin is certainly not discontinued. This is a great one. So it says seizures. I'm pretty sure this was like a black box warning at one time, which is why they like tended not to reach for it, because it lowers your seizure threshold technically. The reason is because it's a norepinephrine and dopamine reuptake inhibitor, which basically makes it an amphetamine, right? This is like 75% of cocaine, right? But it doesn't affect serotonin, which is what makes it different. But because of that, it wires you up. It also decreases your appetite. But the key here is you get no sexual side effects. So if someone is on an SSRI and they can't tolerate it because they lose their libido or they can't maintain an erection, you switch them to bupropion. And that's when you're going to say bupropion. Or if somebody is like kind of depressed and their SSRI is not really working and they're also a smoker and they want to stop smoking, or if they also want to lose weight, it works as a combo drug for that. The big thing here, you never give it to someone who has an eating disorder. The reason is because it kills your appetite. Very, 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 very important to know. You do not give Wellbutrin to somebody who has an eating disorder. So bulimia, anorexia, binging and purging, anything. Any eating disorder at all, you do not give Wellbutrin. The other one on here that gets asked about a lot is trazodone, also known as trazobone. Listen, man, I knew that this was called trazobone in undergrad. Remember that. Got to remember that. Why? Priapism. If someone has an erection they can't get rid of, it's because they ate trazodone. That is the only time this will ever be asked about. I almost guarantee it. Mirtazapine, I don't. They really, really, really don't ask a whole lot about this. I think the only time mirtazapine's ever asked about is if you're trying to increase somebody's appetite. Maybe put like a half of a star here. You should know that mirtazapine increases appetite. All right, so on ADHD meds, right? So you have your stimulants and you have your non-stimulants. Your stimulants are basically amphetamines, and then your non-stimulants are basically everything else. All right, so ADHD drugs. So there's 2 mechanisms of actions. Either you increase the amount of neurotransmitters released in the synaptic cleft, or you decrease the amount that's reabsorbed, right? So amphetamines. You don't really need to learn the name of these because every single one of them says amphetamine in it. You should never look at an amphetamine and not know that it's an amphetamine. So they increase reuptake, decrease, or and also increase release of dopamine. But they only, or I'm sorry, they decrease reuptake and increase release. And then they only decrease reuptake of norepinephrine. They do not increase release of norepinephrine. It's only dopamine that have the effects on. These are they want you to know that they're super abuse and addiction prone. Also, they cause hypertension and arrhythmias. Atomoxetine is a non-stimulant ADHD drug. This one gets asked about a lot, mainly because if somebody cannot take an amphetamine, if you have like a school-age child that you don't want to start an amphetamine, if it's somebody who has a hypertension or an arrhythmia already, or tachycardia, you cannot give an amphetamine. You give atomoxetine. This only blocks norepinephrine and dopamine reuptake. This does not increase the release of dopamine. This has the exact same mechanism of action as Wellbutrin. It just works better for ADHD than Wellbutrin does. Wellbutrin, bupropion works better for depression. And then you have viloxazine. This blocks norepinephrine and serotonin. I don't think I've ever seen a question asked about this. And then you can use tricyclics technically to treat ADHD, but really shouldn't be giving tricyclics or monoamine oxidase inhibitors as like an answer choice unless for some reason they've been rolled out. All the other answers have been rolled out in the STEM already. All right. On to anxiety disorders. All right. Anxiety disorders are important because they're the most prevalent disorders. In order for someone to have an anxiety disorder, it has to interfere with their day-to-day. If it doesn't say somewhere in the STEM that their symptoms and their thoughts are affecting their daily function, either at home or at work or in interpersonal relationships or in school, you cannot give them an anxiety disorder. It's just like depression, right? And there's actually a really strong neurological basis for anxiety. So when someone comes into the ER and they think they're having a heart attack, and you tell them, oh, it's just anxiety, and they get mad at you because they think you're dismissing them, you're not actually dismissing them. And if you know a lot about psych and you know a lot about cardiology, your sympathetic nervous system and your autonomic nervous system are just excessively overactive. So it's basically locking you into a fight or flight response, right? So you have less serotonin and less GABA. You have more norepinephrine and more glutamate, right, which is activating. You're going to learn about these later, but I want this to be in the back of your head because they ask questions about this very specifically and directly. You're going to have a hyperactive locus coeruleus with more norepinephrine, and you're going to have a hypoactive raphe nuclei with decreased serotonin. This is your essentially like fierce, like this has to do with like your fear circuits and like your reward circuits. I've literally seen both of these asked just directly. Patient has anxiety. What part of the brain is most likely causing this problem? And it'll like be like an increase in norepinephrine in the locus coeruleus. I've also just seen them literally, and you're going to learn this later, talk about anxiety and point to a bunch of spots in the brain and ask where the problem is. Actually, I think the raphe nuclei was the answer for that one. And like all of the other disorders, timing is everything. To be diagnosed with actual anxiety, it has to be at least 6 months. Adjustment disorder has to be less than 6 months. Your panic disorders have to be more than a month. Oops. All right, so generalized anxiety. You have to be anxious about more than one thing. This is the key for all these questions. The patient will be anxious about multiple aspects of their life. They cannot be, if someone is super worked up and obsessing over a specific problem, one aspect of their life, it is not generalized anxiety disorder. You have to have multiple concerns. And you have to have 3 more of these symptoms. It's actually only 1 or more symptom for kids. Kids shouldn't be anxious. They really have nothing in life to actually worry about. Well, most of the kids will be seeing at least, except for those who go into pediatric oncology for some silly reason. But this is the mnemonic for this is crimes. Right? You're worried about crimes. So the symptoms are concentration deficit, restlessness, irritability, muscle tension. So you're super worked up. You'll be low energy. It's really fatigue. You can't sleep, so you're tired throughout the day. That makes sense. And then again, you can't sleep, so you're tired throughout the day. Also, they can't have like another condition. So you can't have like a heart condition that is making you tacky at like 185, and then give the person generalized anxiety disorder. Because if you fix their tachycardia with a beta blocker, which is also sometimes used to treat anxiety, their symptoms probably go away, right? And it has to persist for 6 months, and they have to have it for most of the time. The big thing here is multiple aspects of life. If you see a question and the person says, I'm anxious about this, I'm anxious about that, I'm anxious about this, it's almost always generalized anxiety disorder. Usually it'll be like work and their kids, or work and their marriage, or something like that. Or maybe it'll be work and like gaining weight because they're trying to like throw you off. If they're anxious about multiple things, generalized anxiety disorder. Like everything else in the whole world, you treat it with SSRIs first. Then you have buspirone. This is not bupropion. This is not Wellbutrin. This is Buspar. We'll talk about this in a second. But you treat generalized anxiety disorder with SSRIs first. You can also use benzos for like acute symptomatic treatment, but it doesn't fix the problem. It's a band-aid solution. And then use beta blockers to treat the like anxiety induced like cardiac problems. Also CBT, right? This is our combination again, CBT, SSRIs. Social anxiety. This has to persist for at least 6 months. The key to social anxiety is you're worried about what other people think of you. You don't want to be in a public setting or a professional setting or a scholastic setting because you're worried about the impression that other people are going to have. You are not worried with your performance at work. You're worried about people thinking you're bad at your job. You are not worried about your performance at school. You're worried about people thinking that you're a bad student. Agoraphobia. This is everyone colloquially knows this is a fear of open spaces, but that's not really quite true. Really, you're in a place that you can't escape. So it's actually open spaces or closed spaces. And it's mostly like big crowds. Big crowds, public transportation is where they'll usually kind of hammer this in. And it's basically that the key is you feel trapped. You feel like you're in a situation you can't escape. And then specific phobias. I don't know if I've ever seen them test on this, but if it doesn't last for at least 6 months, it's not a specific phobia. Meds don't work, so you have to use like exposure therapy, right? This is when, if you ever see a question on this, it's probably going to be about like desensitization or like flooding, right? Know the difference between desensitization and flooding. So desensitization is like, I'm going to gradually introduce you something that's closer and closer and closer and closer to the thing that you're afraid of until I expose you to the thing that you're afraid of. Whereas flooding is, that's like what we think of when we think about like actual exposure therapy, where like if you're scared of spiders, I'm going to show you a picture of a spider. A lot of times they've actually been using VR headsets for this, right? Kids who get attacked by dogs and like get like really traumatized by it, instead of like bringing them in to play with puppies like they used to, right? Because a lot that can still be traumatic for kids. They actually put them in VR headsets and let them like sit in like a virtual dog park, right? And like they'll reintroduce things like that. All right, I know you guys haven't learned this yet, but everything like counts it as part of anxiety disorders. So I'm just going to mention this because there's 2 things that you guys really need to know that I think are going to make this way easier for you and that I think people miss. Okay, so panic disorder. Everybody knows what a panic attack is, right? But panic disorder. In order to have panic disorder, you need to have the panic attack symptoms. You have to have a panic attack, a verifiable panic attack. If a patient comes into the hospital and they think they're having a heart attack, and it is the first time they've ever had a panic attack, they do not have panic disorder. What happens is after the initial panic attack, they fixate on the potential of having another one in public. In order to have panic disorder, your concern is that you're going to have another panic attack. It's always in the back of your head. You go to work, you're worried you're going to have another panic attack, right? Then they work themselves up, and it could potentially precipitate another panic attack. But the key thing here that a lot of people miss, and you should never miss these questions, is you have to have a history of at least one panic attack, and you have to be fixated on the idea of having another one. And that has to cause behavioral changes. Maybe you stop taking public transportation because you don't want to have a panic attack on the bus. Maybe you stop driving because you don't want to have a panic attack and having to pull over on the side of the road. Maybe your first one was while you were driving, right? The key here is initial attack followed by worry about another one. That's what makes it a disorder. And again, this is one of the OPPs, right? OCD, panic, and PTSD, right? Treat with venlafaxine, or our classic CBT and SSRI, use benzos to treat acutely. Separation anxiety, they'll talk about these symptoms. Really what it is a kid's worried of someone in their life being removed from their life. So they're not worried about being physically distant from the person. They're worried about that person being somehow taken away, like permanently. This should be really obvious in STEMs. You don't treat this with drugs, CBT, and family therapy. Selective mutism, kid talks at home, doesn't talk at school. That's all there is. It'll say it. They'll want you to distinguish this between a learning disability. Usually, they'll set you up to think that the question's a learning disability question, but then it'll say the kids communicates fine at home. Selective mutism. Oh, and it has to interfere with education, like everything else, right? In kids and adults, it's usually interferes with personal life or work. In kids, it's usually interferes with school. For all the disorders. OCD. This is another OPP, right? Treat with venlafaxine. Obsessive compulsive. 2 parts, requires 2 things. You have to have obsessions, which are intrusive thoughts that you can't think yourself out of, that you can't ignore, and you have to have compulsions. The compulsions do not and are usually not in any way related to the obsessions. Compulsions are rigid patterns that you have to follow. Maybe you have to wash every dish 3 times before putting it in the cabinet. Maybe every time before you leave your house, you have to walk in and out of your dining room twice. It will be the STEM will mention a very specific repetitive thing that the person absolutely has to do, and they do it because it relieves anxiety. It is not in any way related to the obsessive thoughts that they're having. It is not in any way related to the anxiety that they're having or the thing that is causing the anxiety. It'll be a completely unrelated thing that they absolutely feel compelled to do, and they do it because it relieves anxiety. They say it's supposed to be time consuming, more than 1 hour a day. They never mention times in question stems. It'll just be really obvious that it's affecting their life. You treat with combo therapy like everything else, behavior and farm. They won't be specific. They'll just talk about doing some type of psychobehavioral therapy. But you treat with high dose SSRIs and tricyclics in combination. They have an additive effect for treating OCD, or you treat with venlafaxine. The answer is basically always venlafaxine on the test. I'm just going to say it. I've never seen them ask about OCD and it not be venlafaxine. And the people at high risk are anyone with a history of childhood abuse, physical, verbal, sexual, and anyone with a family history of OCD. It's wildly high. The twin concordant studies, if you're a monozygotic twin and your twin has OCD, there's a 60% chance that you're going to have OCD. So for whatever reason, it's very genetic. Body dysmorphia. I like to think of this as imagined ugliness. You have an obsession with a flaw in your physical appearance that's not real. It is imaginary, or it is insignificant compared to other people. We're not talking about people who are depressed because they spilled boiling water on themselves or burned themselves and now they're permanently disfigured. This is somebody who looks normal to any other human being but sees a glaring problem with themselves. And this leads to the development of repetitive behaviors. So a lot of times they'll get skin picking or excoriation. They'll be obsessed with their appearance. They'll continuously check themselves in the mirror. They'll look at their phones to take pictures of themselves. And they're constantly seeking reassurance. I cannot express enough. It is an imaginary or insignificant. There is nothing wrong with this person. They just think there's something wrong with them. This is not an eating disorder, and it's not related to eating disorders. Sometimes they'll be like, oh, well, you have body dysmorphia that leads to anorexia. No. This is an imaginary thing. And it's not related to gender dysphoria at all. This has nothing to do with gender dysphoria. This has nothing to do with transgenderism. You treat with cognitive behavioral therapy and SSRIs, like literally everything else in the world. Something that I've seen them ask about in physician response questions. You should be really hesitant to treat this surgically. You shouldn't treat this surgically. The answer will be don't treat this surgically, because there's nothing wrong with these people physically. but they're obsessed with the shape of their nose, right? Or their, I think like there was like an episode of like one of the doctor shows where like someone wanted their arm cut off or something, right? So you do the procedure, and then because they don't feel better because there's never a problem to begin with, they become very violent against you. They sue you, whatever, right? You avoid cosmetic procedures. Do not do cosmetic procedures on these people. Treat with SSRIs and CBT. But the important thing is, if I haven't said it enough times, is it does not exist. The problem does not exist. Actually, I love Dr. Bro, but on one of her slides, she's a picture of Michael Jackson, and I vehemently disagree because Michael Jackson did not bleach himself white because he wanted to be white. Michael Jackson had vitiligo and didn't want to be two different colors while performing on stage, and it was too much of a pain for him to put on the dark makeup before going out onto stage, so he just bleached all of his skin the same color, right? That is not body dysmorphia. He had an actual problem. There's no actual problem in body dysmorphia. And the only reason I'm harping on this is because I've seen way more questions on this than you would think, or it's like a bait answer. And it leads to excoriation, which is skin picking. Usually they start by picking at acne or scabs. There'll be like some type of lesion on their body that they can't stop messing with until it just gets worse and worse. And then eventually they just start creating lesions. This will also happen in like cirrhotic people who like have the itching. And then with comorbidities of psych disorders, they'll they can develop this and they'll start like really picking at it. And then trichotillomania is hair pulling. The big giveaway for this in any question they're asking about it is the hair will be broken and at different lengths. It will literally tell you that the hair shafts are in variable lengths. The answer is always trichotillomania. It's hair pulling. They do it because it relieves tension or because they feel good about doing it. It is not related to OCD. They're not doing this because they're obsessed with the way that their hair looks. They're doing this for completely unrelated reasons. It just makes them feel better. It just relieves their anxiety. And again, SSRIs and CBT. Literally everything is SSRIs and CBT. All right, so sedative drugs. The biggest thing here is differentiating between barbs and benzos. And I'm going to explain very specifically why in a second. Barbiturates increase the duration of the chloride channel openings. Benzos increase the frequency. I guarantee you this will literally be a question. Increased duration for barbs, increased frequency for benzos. You need to know this 1000%. This also means, because this increases the duration of the channel's opening, circumvents the refractory period, which is like, nature's check, right? There's not really a ceiling on CNS and respiratory depression, which means if you keep giving somebody barbs, eventually they'll just stop breathing. Benzos have a ceiling effect. You can only depress their central nervous system and their respiratory system so much with benzos. Also, barbs have no antidote. Benzos have flumetazole. And then, in case you didn't know, alcohol is also a GABA agonist. So the chloride channel, there's actually 4 binding sites. There's one, benzos, barbs, GABA, and alcohol all actually have different binding sites to the channel. But listen, if I could put more stars on the slide, I would. You have to know this. I guarantee this is a question. I guarantee like it will ask you about this 1,000 trillion %. And then know the ceiling effect. It's really, really important. And just like to really illustrate that, right? So like benzos, you keep giving more and more doses, you'll continuously suppress the CNS until you put the person in a coma. Whereas benzos, the best you're going to get is you're going to knock them out. All right, so with the subclasses of benzos, they break them up into short, medium, and long acting. I highlighted and read the ones that you need to know that I see. These are also the ones that Dr. Paul says you need to know, so that's a happy coincidence. Short acting is Midazolam, is the one that I always act about. Medium acting is alprazolam or lorazepam. I've seen clonazepam, but you should know that these are the medium acting ones. Usually when they're asking a question, it's about the medium acting ones. And then long acting is diazepam's the most common one they ask about. The short acting ones are Tom. Someone said once Tom doesn't last very long in bed, and I thought that was funny. So now I remember that forever. The other thing you need to know is the LOT benzos, LOT, so lorazepam, oxazepam and temazepam, right? Short acting, and medium acting. They have extra hepatic metabolism, so they're not broken down the liver. So what that means is they're safe to give to alcoholics and cirrhotics. All these other ones are broken down in the liver, which means that anyone who's an alcoholic or a cirrhotic, it will accumulate and it gets worse and worse and worse and worse. And you'll end up with essentially sedating the patient on accident. Diazepam and the thing that diazepam breaks down into are both the same. Like, well, they both have the same effect, which is why it lasts long. And it's much worse in patients with liver failure because essentially it has to go through hepatic processing twice. So you kind of get a double action. Rohypnol, these are roofies. These knock you out and you don't remember it. Everybody knows what roofies do. It's why you can't leave your drink alone at the bar at a frat house. Yeah, Rohypnol. It's called flunitrazepam. I think I've seen like one question that used its actual name. And then Atom. These are the most addictive ones. So these have the highest potential for abuse. It's not really hard to imagine the short-acting ones, right? Short-acting drugs is just like the opioids. They have the highest use for abuse and addiction. And then alprazolam is the fourth one. I've seen a question directly about this. It'll say like, which of these should you not give to the patient? And it will be literally like clonazepam, lorazepam, diazoxide, diazepam, and alprazolam. And you have to be, oh, you can't give them alprazolam because that's the most addictive. That's one of the addicting ones. Buspirone. This is Buspar. Do not confuse this with bupropion. The reason I say this is because I've done it multiple times. You just see it, you're like, oh, well, Butrin, sick. Or, oh, it'd go in the other way. Oh, Buspar, sick. Do not confuse these two. I know that they look so similar. My brain registers these as the same ones, right? Buspirone is a serotonin agonist. Buprenorphine is a dopamine and norepinephrine reuptake inhibitor. So you use this because it's like a benzo and it functions similar to a benzo and a barb practically. Atom, it stands for those are the addictive ones. So it's the short one acting ones, right? So it's alprazolam, triazolam, oxazepam, and midazolam. So I should have put these in order so it's not backwards. But like if you remember the short acting ones are Tom also, right? You're literally just adding alprazolam to it and they become the most addictive because if you remember with opioids, short acting, higher potential for abuse, more addictive. Whew. All right. Buspirone. With the serotonin receptor agonist instead of a GABA functioning drug, right? It's just less used for dependence. So uses for chronic anxiety and depression. If somebody's already on an antidepressant, I don't really think you're going to be tested on this, but if somebody's already on an antidepressant, they tend to start on buspirone before reaching for a benzo or barb because it plays better with antidepressants than they do. All right, sleep drugs. This is really simple. All the sleep drugs have Z in them. Zolpidem, Zolaplan, and Ezoplicone. Look for the Z. If it's a sleep drug, look for the Z. So these bind only to the GABA receptors with alpha-1 subunits, which makes them a lot more specific than benzos and barbs, which is why you don't really get dependence on them. You can still develop like sleep dependence, but you don't get like addicted to them. These two, Ramelteon and Suvorexant. Okay, listen, I don't think you guys have done this yet. Quick aside, the actual pathophys on how this works, on how the what is it, melanopsin, the rhodopsin in your eyes, and like the pathway, and it's actually backwards. It's like a constitutively active series of neurons that's inhibiting other neurons, which are inhibiting other neurons. It's very complicated. But what is not complicated is everybody knows that melatonin puts you to sleep. Ramelteon is a melatonin agonist. They use it for jet lag and swing shift, fixing workers with swing shift sleep disorder. So basically anyone who works in the ER, right? Suvorexant is an orexin, which is also known as hypocretin. I've seen them use both of these terms before. Antagonist. Orexin is the wake hormone. Melatonin is the sleep hormone. During the day, our body produces orexin. During the night, our body produces melatonin. Ramelteon is melatonin. Suvorexant is orexin. That's all you need to know. All right. Wow, I can't believe it's exactly 8 o'clock. That's crazy. Okay, I need like 5 minutes. And then we're going to start more or less the real reason y'all are here, because this is the meat and potatoes of honestly all of the. This is all the neuro. This is all we're about to do. All the neuro, basically, the actual neuro for the body. So 5 minutes, and we'll regroup. Does anybody have any questions before I take off for 5 minutes? See somebody typing? No. All right. If you have a question, type in the chat. I'll address it when I get back. I'm gonna get water and use the bathroom. I'll do like one more minute and we'll get rolling. Anybody have any questions before I restart? This is all right. Spinal tracts and lesions. All right, so we're gonna do the spinal cord, then we're gonna do the brainstem, and then we're gonna integrate them. This is so much of the exam. You absolutely have to know the rest of this PowerPoint, and you don't need to know it in like a I flashcarded what a medial pontine injury is. No. You need to understand the path of the nerves. You need to understand where they come out of each part of the brainstem, and you need to understand the blood supplies for the areas. You need to understand where the tracts go. You need to understand where they cross, where the decussations are. When you understand those things, you don't have to learn any other neuroanatomy, because it will just make sense to you. And I'll show you what that means. I know you guys haven't like technically done cranial nerves yet, but we're going to touch on those too. You learn them in MSK, and this is fifth semester, so you need to know everything now because you have comp in like 2 months or whatever, 3 months, 2.5 months. So it's fair game. But you have to know the cranial nerves to do a lot of the brainstem stuff. It makes it a lot easier. So we'll just do like a brief refresher. I'm sure you guys know them better than you probably think you do if you haven't gone over them yet. I think tomorrow is it's tomorrow's OLMs, but anyways, continuing on. All right. So right off the rip, I'm just gonna do some rapid fire facts, flashcard facts that they like to test on for the spinal cord. If you don't remember them from MSK, if I didn't mention them on Tuesday, here they are. L1, L2, conus medullaris. This is where the spinal cord ends and it becomes the quada equina. Basically, instead of one chunky cord, you have a bunch of fibers suspending down. Why is this important? This is where we do lumbar punctures, L3, L4, even with the iliac crest. I've seen them ask very directly, very specifically, both. Where do you put the needle? And L3, L4 has been an answer. And then asking what uses landmark, iliac crest. Both of these have been questions. They've both been questions on forums. They've both been questions on exams. They've both been questions on UWorld and about absolutely 1000% know this. Dermatomes. Look up a dermatome map, get a general idea. I think in the step book they have it broken down of like, oh, from here to here is the arms, from here to here is the torso. You can usually figure it out, but the two you absolutely need to know. T4 is the nipples, T10 is the umbilicus. They love to ask like a spinal cord issue, and they'll say like loss of sensation at the level of the umbilicus, and then ask you what the vertebrae is that the injury is on, and it'll be like T10, right? They love to know this. Okay. Also, as you descend down the spinal cord, the proportion of white to gray matter decreases. And this should make sense to you, right? Because the gray matters is the cell bodies before the axons project out, like, right? Like the neuron bodies, and then the axons project out. Whereas the white matter is the tracts that are going up and down. So the cervical vertebrae, or the cervical spinal cord, has a lot more tracts running through it because it has all the tracts on the arms, all the tracts on the torso, all the tracts on the hips, all the tracts on the legs, than the sacrum, which only has the tracts on the legs, right? They're coming up. So you have more white matter at the top, and it gets less as you go down. I have seen them more or less directly ask this. Also, you should understand how the general shape of the spinal cord changes, because I've also seen them literally just show a picture of a cross section and ask you if it was cervical, thoracic, lumbar, or sacral, basically. Thoracic's a dead giveaway. I think this is the one they like to ask about the most. The reason is they have the lateral horns, right? What these right here? What are the lateral horns? The lateral horns are basically where the autonomic nervous system juts out to control everything, right? Your breathing and your heart rate and all that. And then as you get to the lumbar region, and you get lower to the sacrum, you'll see that the ventral horns start to get a lot bigger. And the reason the ventral horns get a lot bigger here is because this is where all the cell bodies are for the neurons that are going to project down into the legs. So it gets chunky here. I've also seen that asked. So know that, right? Just know this. Reflexes. I'm going to give you guys 5 questions right now. I guarantee this is going to be, you're going to get 5 questions right across your comp exams and STEP with this slide right here, right? Your reflexes. I don't know if it's from MSK. This is super high yield. Make sure you know this. This comes up all the time. Also, you can cheat most of the brachial plexus questions by just knowing this stupid rhyme, okay? Achilles reflex. S1, S2, buckle my shoe, right? Patellar reflex. L3, L4, kick the door. Biceps and brachioradialis. C5, C6, pick up sticks, right? Triceps reflex. It says C6, 7, 8, but you can just say 7 and 8, lay them straight, okay? Knowing those nerve roots will give you so many. Now, they also have, God, I hope you guys can see me, otherwise that won't make any sense, nearly as much sense as it should. Cremasteric reflex is L1, L2, testicles move, right? Anal wink reflex is S3, S4, wing scalar. This is so stupid, but again, it's the stupid ones that you remember, right? This isn't as important. The reflex getting is important, but I'm telling you, you can cheat so many questions like this. When I do this stupid rhyme in my head on the test, I actually make it even more. I even one up, and this is how I answer basically all the brachial plexus questions, right? So C5, C6, pick up sticks, right? I just lift my arms up, kind of like T-Rex arming for C5. C6, wrist extensors, right? Then C7, elbow extensors. And then C8, I like tuck my fingers in, right? So boop, 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 right? I do this on every exam. I probably look like a lunatic, but you know what? I've got all the brachial plexus questions right because of this, right? Because you know that your flexors are your radian nerve and your extensors are your median nerve. And sometimes it can be kind of obtuse because they'll ask you what the nerve root is damaged and they'll give you a bunch of symptoms. You're like, oh, well, I know it's the radian nerve, but the radian nerve is technically innervated by 5, 6, 7, and 8. And so is the median nerve, right? So just this free point. These are free points. These are so many free points. So I just thought I'd mention it now. All right. Spinal cord organization. You need to know everything on this slide. And not like, oh, you should be, no, you need to know everything on this slide. Not be familiar with, you need to know every single thing on this slide. Right? We're going to start at the top, right? Dorsal column, right? This is your pressure, your vibration, your fine touch, proprioception. In the middle, this is arranged from tail to head, right? The middle's the tail. So you have your sacrum in the middle, medially, and then cervical is laterally. So you have your fasciculus gracchalis in the middle, right? Gracchalis, G for ground. And then they'll say lower body. Like legs, no, G for ground. It's G for ground. Okay, G for ground. It's medial. And then you have your cuneatus, which is the lateral portion, which is your upper body. I like to think of this part as like if you think about like banana peel, like if you were to lay banana peels over somebody, like where the nerves are on, I know some people find that confusing, but it makes sense that the neurons that come from the bottom, like furthest down from you, have to be more towards the middle, because then as they come up, the other ones will like kind of be joining them, right? So your ascending tracks. And then outside of the body or in your anterior cord, it's the opposite, right? So now you have your cervicals closest to the middle, and your sacrals out on the side. I have no good way to remember this. The only thing that I remember is I remember this, and I remember that all of these are opposite, and that's how I remember it. The other thing that they sometimes comes up that a lot of people don't really pay attention to or remember is this right here, your anterior corticospinal tract, right? So your corticospinal tracts are responsible for your motor function, your lateral corticospinal tracts. The interior ones, this is mostly like for your trunk. And because of that, and because of the way that most of these injuries happen, this is usually bilateral. And it's very rarely ever, because also these like decusate, they don't follow the same rules that everything else does. You're basically never tested on this specifically, but it is important to know that like this is the trunk. Right. So, and the other thing too is I know I'm kind of all over the place on this, but there's just corticospinal. They all of the names give away what they do. So if you don't remember, right? So it's from the cortex to the spine. Those are descending fibers. That it literally tells you the direction that they go. The only thing that we're sending down our spinal cord is motor function. Spinothalamic. What does the thalamus do? The thalamus processes senses, right? So it's from the spine to the thalamus. You're ascending pain and temperature. And then your anterior spinothalamic is your crude touch and your pressure. Most people forget this. To be honest with you, that's okay. If you go by pain and temperature here and pressure, vibration, and fine touch for dorsal column, you'll get basically every question right still. You can normally basically completely ignore the crude touch and pressure. I don't think I've ever gotten a question wrong because of like the crude touch or the pressure, right? So now the really important thing to remember is, and this is what I think trips a lot of students up, the spinothalamic tracts, it comes in the posterior horn and it crosses basically immediately and then shoots up the lateral spinothalamic tracts. Whereas the dorsal column and the lateral corticospinal tracts, they cross in the rostral medulla. This is how you end up with like different distributions of ipsilateral and contralateral paralysis versus pain and temperature loss versus proprioception loss. This is how you can tell if a lesion is in the spinal cord or if it's below or above or in the brainstem. This is why it is really important to understand the actual pathway that these take and the anatomy, because it is too much to just try to remember every use case. And instead, what you need to do is you need to look at the symptoms and you need to say, okay, these are opposite, then it must be above the brainstem or in the brainstem. Okay, these are on the same side, it has to be below the brainstem. And we will go through a bunch of examples, like we can go through a bunch of examples, but please know that. Please, these are the things you need to pay attention to. Okay, didn't really talk about this. This doesn't really matter until you get to your, the ordered neurons don't really matter until you start talking about upper and lower motor neuron injuries. And basically, you're gonna be talking about your corticospinal tract, right? If the lower neurons are damaged, you don't get inhibition from the brain, and they become hyperactive. Oh wait, no, I said that backwards. Forget it. Forget it. You guys don't need to learn this yet. The first order, second order, and third order neurons, they don't matter until you start talking about upper and lower motor neuron injuries. But you should generally know that the ganglion are the first order neurons, and then everything in the tracts, basically after they cross, is the second order neurons. That's like the only thing that you should take away from the slide. As far as cord injuries go, they're never going to ask you about like the type of injury, but you should be aware of the types that exist. And you should be aware about, I guess technically they will ask you. So they'll ask you about hyperflexion and hyperextension, specifically of interior versus posterior cord. And what this will basically be is they'll describe symptoms and you have to identify that it's anterior cord syndrome. And then they'll ask, what likely caused this, and they'll be like syphilis and polio, hyperflexion versus hyperextension, and you know that anterior cord is hyperflexion, and which is usually like falling downstairs, right? Like, and this usually happens in the neck and the cervical vertebrae, so it's like whiplash. So they have a guy falling downstairs, or also they have hyperextension as a car accident, but also like hitting the steering wheel, right? Or hitting like the airbag. We have airbags to avoid hyperflexion injuries in the neck. The other thing you need to know is like the key sites of breaks. So C1, C2 axis and atlas, your atlantoaxial instability. This is your Hangman's fracture. C7, this is when because your neck is much more flexible than your cervical vertebrae are much more flexible than your thoracic vertebrae. So where the cervical vertebrae and the thoracic vertebrae meet at C7, that like area is highly susceptible to breaking. Your thoracic vertebrae are much more flexible than your lumbar vertebrae, so it makes sense. And then the other things that you need to know is C4. If the fracture is above C4, you can have quadriplegia, and it also be fatal. Why? Because C3, C4, C5 keep the diaphragm alive, right? So if you lose, and if you have an injury C4 or above, you can lose respiratory function, and then you end up in an iron lung. Actually, I think the last person in iron lung just died recently. I could be wrong on that, but and then if it's above T6, they ask about this. 110% they ask about this. So if you have an injury above T6, we talked earlier about how the thoracic vertebra or spinal cord has the horns, right? The lateral horns. You get what's called autonomic dysreflexia. So basically, you can't feel that you have some type of noxious stimulus. So it's usually like a full bladder, right? Is what they like to use as an example. So you can't feel that your bladder's full, but your autonomic nervous system can tell that your bladder's full. And your body starts to get uncomfortable, but you don't feel uncomfortable. So what happens is basically the top half of you becomes hyperactive and you start sweating and you start flushing and you get hypertension. But then the bottom half of you is still cold and you have no idea what's going on because you don't have this autonomic response to the whole thing. It'll be really obvious when this happens, and the answer is usually like the patient's bladder is full. You need to insert a catheter, etc. This will also guaranteed be a question. They're gonna ask you like, you need to know this. You need to know that zero, like the muscle strength grading. Usually the big differentiating they have is like movement with gravity versus movement against gravity, right? So it's zeros, you can't move at all. They're not going to give you something that easy. 5 is you're completely normal. And then just kind of goes down a step, right? So you can move fully, you can move against 4 is you can move against gravity and some resistance. 3 is you can only move against gravity. So if like anybody adds any weight to your leg at all, you can't push up against it. 2, they're laying on their side, and then 1 is they basically can just like barely squeeze the muscle, but they can't actually move the limb. Usually it's going to be this. Usually it's going to be the patient can only move against gravity, and then the answer is grade 3. Okay. I really like this image. I would keep this image up while you're studying. I would take notes on this image. I really like this image because it shows all the spinal cord syndromes together. But this image is incorrect, actually, and I'll point out why. But I kind of like the fact that it's incorrect to show this is really complicated. This is a figure. I believe this is from a published paper, and no one caught the problem with this, which just goes to show how crazy complicated that some of these things can be, and why it is really important to, instead of just trying to memorize your way through everything, learn what each of the tracks do, and then when you overlay a lesion, be like, okay, well, if this is knocked out, then I know that that clearly these are the symptoms, these are the motor function that's lost, and this is the like pain and temperature that's lost, etc. The senses that are lost. When you come back to this, like you can see like all 3 colors, right? You lose vibration, pain, temp, and motor loss, right? Because you lose all 3 tracks. Whereas like just like green is just pain and temperature, blue is just vibration senses. This is like anterior cord syndrome, right? Anterior cord syndrome, dorsal column spared. So you're gonna have loss of everything but proprioception. Posterior cord syndrome, basically just the dorsal column. So you're just gonna lose vibration and position sense. But we'll go through each of them together, right? Posterior cord syndrome, you lose the dorsal column, right? You lose the dorsal column, you have no fine touch, vibration, or position sense. You can still get crude touch, right? Because that is here. And this is usually caused by hyperextension. It's not really ever caused by penetrating trauma. It's almost always hyperextension. This, right, dorsal column crosses in the rostral medulla. So if you have damage below the rostral medulla, it will be ipsilateral. And if this tract is damaged above the medulla, it'll be contralateral. Symptom-wise. But mostly for this, you just need to know, you really just need to know that this is dorsal column, fine touch, vibration, position senses. And remember, the middle is a graciculus, right? That's on the ground. That's your lower limbs. So then for anterior cord syndrome, the cause of this they actually like to test on, I think more than anything, is thrombosis of the spinal artery, specifically the anterior spinal artery. So if you look, the posterior, there are 2 posterior spinal arteries, and there's only 1 anterior spinal artery. So if you block one of the posterior spinal arteries, you still have the other one to kind of provide blood supply to the dorsal column, which is why that's usually the thrombosis of posterior spinal arteries doesn't really come up as a question, or as an answer. But thrombosis of the anterior spinal artery, 100%, I've seen it as an answer choice multiple times when they're explaining anterior cord syndrome. And again, anterior cord syndrome, we're losing everything basically except for the dorsal column, right? So we're losing cortical spinal, which goes down, and we're losing spinothalamic, which goes up, right? So motor down, lost, spinal pain and temperature up, lost. Now, the spinothalamic tracts enter and almost immediately cross over, right? Before they go up, right? Up here, right? I like to say in the door, out the vent, right? Dorsal side, ventral side, right? So they go in the dorsal horn, and then they go up in the spinothalamic tracts, right? So they cross here in the anterior commissure. So that's really important because if you have some lesion here at the anterior commissure, you get bilateral loss of pain and temperature, right? But it's not really going to affect your motor, right? Because that crosses in the medulla. Modality. What do you mean modality? Nope, I have these backwards. I see what you're saying. Yeah, these are backwards. I flipped these. I'm sorry. I definitely typed these out wrong. I'll have to fix that and repost the PowerPoint. Does everybody see what I'm talking about? These are wrong. Cortical spinal is 100% motor, right? Brain down. Spinothalamic is 100% pain and temperature. Those are my apologies. So the symptoms are usually, like I said, they're usually below the lesion, because you're going to hit this, and then you're going to knock out all the tracts that are below it that would be coming up. And with anterior cord syndrome specifically, it's usually the whole anterior cord. So it's usually bilateral. It's usually not, you usually don't have to worry about ipsilateral or contralateral, but we can talk about what happens when you do in a second. When we get to the end, after we go through all this, we'll go through like specific, like basically you have a lesion here, this is what happens. Central cord syndrome, you guys are going to learn about syringomyelia. This is anytime central cord syndrome is mentioned, it's almost always in the context of syringomyelia. But basically, this can be caused by either hyperextension of the spine. I've never seen them talk about this. Central spinal stenosis, I have seen them talk about, or disruption of blood flow. Because if you remember, the blood supply comes from the outside of the spinal cord and works its way in. So technically, in theory, if you have like hypovolemia, or you have like acute blood loss, trauma, right? You could decrease perfusion of like the inside of the spinal cord. You get like a central cord injury, but 99 times out of 100, they're talking about syringomyelia. And what syringomyelia is it's in the cervical spine. And it's like basically like a fluid-filled tube. It's really highly associated with Chiari-1 front malformations. And it usually occurs between C2 and T9. And it's basically this tube along the central canal. It's not in the central canal, it's next to it. But it grows outwards. And as it grows outwards, it starts taking everything with it, right? You start losing more and more. So in these questions, the patient will usually just present with a loss of pain and sensation, pain and temperature sensation on their tops of their arms and their shoulders, right? Like the cape distribution. And the reason is because when you the middle starts to get taken out, you're hitting both spinal thalamic tracts in the anterior commissure. And then if it gets really bad, then you start to lose everything, because and it works its way outwards. So you lose motor, and feeling in the neck. Well, in the neck, and then it works its way out to the thoracic and the lumbar and the sacral. Even though it technically goes everywhere, the question stems usually don't talk about a loss of proprioception. I think the main reason for that is because if you don't have any pain and temperature and you're also paralyzed, how can you really discern between proprioception, right? And they're usually talking about patient symptoms. But yeah, it's just important to know that as this grows, you start to take everything with it as you go out. Brown-Séquard, this is why that picture is wrong. Okay, so Brown-Séquard is a little complicated. Basically, it's a hemisection of 1/2 of the spinal cord. Even though it's the most complicated spinal cord injury, it's the easiest question. And the reason it's the easiest question is because you're going to have ipsilateral loss of basically everything. And then you're going to have contralateral loss of pain and temperature, and crude touch, 1 to 3 vertebrae beneath the lesion and below. And this is why that picture is wrong. Because, and this is how I've actually seen them ask this like very directly. So basically, they'll talk about Brown-Séquard and they'll say that someone was stabbed. And they'll tell you that the pain and temperature loss starts at T10, right at the umbilicus. They'll say at the umbilicus, and you need to know that's T10. And then they'll ask where the lesion is, and the answer is not T10. The answer is T8 or T7, and the reason is because when the spinal thalamic tract comes in, we say it crosses right away, but it really doesn't. So the nerves from like this dermatome, the T10 dermatome, they go up a little bit before they cross. And this is like it all the way down the spinal cord. So really, the contralateral loss of pain and temperature is like 1 to 3 vertebrae beneath the lesion and below. And the only way that they can trick you with this question is by telling you that the pain and temperature starts at the umbilicus, starts at the umbilicus, and students are going to be like, oh, cool, I know that the umbilicus is T10, and they put T10, and the answer is actually T8, because the pain and temperature is a little up, which means that on the ipsilateral side, from T8 to T10, you have loss of everything. And then from T10 to below, you have loss of everything except for pain and temperature on the ipsilateral side. And if we go back here, you can see it's wrong because they just have pain and temperature sense, and they use this little chunk when this should really be all 3 colors, right? You should lose everything in this little chunk. And then pain and temperature is spared here. And then proprioception and motor sense are lost here, right? So complicated that they get it wrong in published articles. However, it will be so obvious every time they ask about this, because it's the only thing that causes basically all ipsilateral with 1 contralateral thing. And it'll even say like they were stabbed in the back or something just ridiculous and silly. That just like really gives it away, because it's almost always a penetrating injury. I hope it makes sense. I hope no one's getting lost in the weeds. Is this like clear? Because that is all the spinal cord injuries. So does everybody understand these? And does everybody understand, like, if I was to say, if you put a lesion here, what do you lose? I plan on coming back and going over this at the end more specifically. But if there's any confusion, I want to address it now before moving on, because once you start in the brainstem, you have to understand where all this is coming from once you get into the brainstem, or you're going to flip-flop a bunch of times. This is why it's also super important to draw everything out. And when I say everything, I mean I'm going to give you a little like a cheat sheet diagram that you should draw on the test, and you should look at when you're answering these questions. Don't be afraid to just talk instead of typing also.
Could you explain Brown-Séquard again, where you were talking about where it's at T10, but it's really T8?
Yep, sure thing. Okay, so Brown-Séquard, it's spinal cord hemisection, so you lose half of it. So if you stab someone at T8, from T8 to T10, they're going to lose everything. And the reason they're going to lose everything is because you're cutting off all of the tracks that are moving, right? So all of the pain and temperature that enters at T10 coming like before it crosses over, right? Because like we say, it goes up a few before it crosses over. You're going to lose those, and then you're going to lose the dorsal column, the whole dorsal column. So you lose proprioception, and you're going to lose the cortical spinal tracts. So you're going to lose motor. So from T10 to T8, T8 to T10, sorry, going down from down up, you lose everything. Then once you get to T10, which is the umbilicus, the spinothalamic tracts have now crossed. So now you have contralateral loss of pain and temperature. But when you cut the dorsal column and the cortical spinal tracts, those cross over in the rostral medulla. So those have already crossed over. So you're going to lose motor function, vibration sense, and proprioception on the ipsilateral side from the whole lesion down. The reason they get tricky about it is because, like I said, you hit T8 here, and then from T8 to T10 on the ipsilateral side, you lose pain and temperature. But then those fibers cross over, and now on the contralateral side from T10 below, you lose pain and temperature. So what they like to do is they'll tell you, they'll describe Brown-Séquard, but they'll tell you that they've lost pain and temperature sense from the umbilicus and below. And what students will do is say, oh, I know the umbilicus is T10. And the answer choices will be looking for vertebrae. And they'll put T10 as an answer. But the actual answer choice will be like the lesion is at T7 or T8. Because they want you to know that it hops up a few vertebrae before it actually crosses over and starts to ascend. Does that make sense?
Yes, thank you.
All right, brainstem organization lesions. But first, I'm sorry, you have to know the cranial nerves to even begin to understand the brainstems. I don't like the fact they should have organized this week to give you cranial nerves before you get to the brainstems. I'm really sorry to do this to you guys, but you have to just have a very, at least vague memory and refresher of the cranial nerves, right? So we're gonna go through these real quick, right? Also, circle the Willis. If you can't draw it yet, learn how to draw it by Monday. Because this is all of the brainstem strokes, all the lesions, everything. You cannot even begin to diagnose or discuss these until you know the vasculature and the cranial nerves. Thankfully, it's really simply laid out, right? So you have your anterior cerebral artery, right? We talked about this, and then you have your anterior communicating, right? Most anterior cerebral. Then you have your internal carotids. They're always drawn going inwards, right? So they make it really easy on you. You have your MCA, right? This applies basically the whole sides of the brain. Right? We good? Cool. Okay, now we get to the brainstem, right? Posterior cerebral and superior cerebellar at the top. Then they break down into the basilar arteries, right? And then you have ICA. And then you have your vertebral arteries and your interior spinal. And then you have pica. The cranial nerves 1 and 2, they kind of do their own thing. They come right out the top, right? We know what these are. We know what they do. And then they go in order, right? 3, 4, 5, 6, 7, right? 5 is the trigeminal. 6, 7, 8, 9, 10, 11, and 12. Right? Okay, real quick. I think we learned these for the MCAT. You definitely learn them in OSK. In case in case you just don't remember, just so quick. to touch and feel very good. Velvet heaven, right? That's a stupid mnemonic they use. And then the other one, some say marry money, but my brother says big brains matter most, right? Sensory, that describes whether they're sensory or motor. Before every exam, I just write the mnemonic. I just do O, T, A, F, V, G, V, A, H, And then I do the some say marry money, but my brother says big brains matters most, right? You should do that every exam now moving forward. Both the neuro exams, the neuro final, Comp 1, Comp 2, USMLE, all of your forms, just write those out because you're going to get to a question and it will save you time in the long run if you just write it out at the start of the exam. Again, I'm telling you guys to write these things out. You are allowed to start writing on your sheet of paper as soon as the instructions for the exam begins. So you have, I think it's like 12 minutes basically before you actually get to the first question of time where you are, according to USMLE, allowed to write on that sheet of paper. Use that time to write all these things down. All right, so now we've done that. I mean, we can hop back to the brainstem. All right, so the brainstem, they like to flip these on you. The ventral, this is the ventral side, right? When you're thinking about like when they're pointing to like cranial nerves, they're usually pointing to the ventral side. And then the dorsal side, the way that I know it's the it's the dorsal side is you can look for the cerebellar peduncles. And then you can still see the cranial nerves coming out the side. But if they're pointing to cranial nerves, it's usually gonna be the ventral view, right? So you start with the midbrains, and then you have the pons, and then you have the medulla, right? Again, I cannot hammer this in enough. You have to know this. 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 You have to know all of this. You need to know all of this. It seems like a lot. I promise you it's not. It is much easier to just learn to draw this than to try to just memorize, associate everything. I promise you can learn how to draw this whole thing in not even like a full episode of some Netflix show. So the midbrain, right? So the midbrain is the top of the brainstem, right? So medially, the midbrain is supplied by the basilar artery. Laterally, it's supplied by the PCA and the SCA, right? The posterior cerebral and the superior cerebellar. The pons is blood supplied by the pontine arteries. They call them labyrinthine arteries here, but they call them pontine arteries or perimedial arteries of the basilar artery. And then laterally, it's supplied by ICA. So anterior, I think it's like forward, right? Because the pons is more forward, up, right? I guess rostral. Then the medulla, which is supplied by pica, right? So then in the medulla, you have your median medulla is supplied by the anterior spinal. And the lateral is supplied by either your vertebral arteries, but they're usually looking for pica, right? And I have the little acronyms down here. These are the perimedial arteries that you can see here. They work their way into the brainstem. And then yeah, right. So you know the blood supply. You have to know the blood supply. But it's really easy to remember the brainstem because of the rule of fours. And this is what you're going to draw out, and this is why you're never going to miss one of these questions on the exam, right? Okay. So the vertical distribution, each section of the brainstem gets 4 cranial nerves. C1 and C2, if you remember on Tuesday, I talked about C1 and C2 are different, right? The olfactory, right? And the optic, right? So, I'm sorry, the olfactory and the no, yeah, it is the optic. It's the optic. It's the optic. Sorry, I'm stupid. Anyways, they're myelinated by oligodendrocytes, right? Not Schwann cells. They're a little bit special, right? So you can usually ignore these as far as like talk about the brain stems, but they count them as 1, 2, 3, 4, right? So you have midbrain and up. You have 1 through 4. C1 and C2 are honorary members. Then in the pons, you have 5, 6, 7, and 8. You have the middle 4. And in the medulla, you have 9 through 12, which are the bottom 4. Then horizontally, all of the motor nerves are medial. M for motor. They also, with the exception of 2, are all the factors of 12. What do I mean? 3 and 4. They're both motor nerves. They're both medial in the brainstem. 3 times 4 is 12. 6, they have Dussen's nerve, right? It's medial. It's also a motor nerve. 6 times 2 is 12. 1 and 2 are exceptions. We don't count them. Hypoglossal, it is also medial. It is the other medial. It is also motor nerve. 12 times 1 is 12, right? They're all factors of 12. It makes it really easy to remember. Sensory nerves are lateral. So if you have a lot of sensory symptoms, right? Facial nerve. It's a lateral injury. And then the mixed nerves are in between, but like you can usually figure it out. So I know that you guys haven't fully done the cranial nerves and you haven't really done fully brainstem strokes, but I'm going to tell you this right now. This is how you answer all of the brainstem stroke questions. But I don't think it has ever failed. The cranial nerve lesion is always ipsilateral. That's it. Cranial nerve lesions are always ipsilateral. You can almost always figure it out. If somebody has problems with abduction of their eyes, you know it is a medial ipsilateral pontine injury. And that's how you need to think of all these questions. Always look for the cranial nerve first in any question about a brainstem lesion, because it will always be on the same side. The only time that doesn't like super work is if you have like a cortical stroke. The signal to move the facial muscles won't be being sent, and then it gets a little then it's not so straightforward. But like when you're talking about brainstem strokes, when you're talking about brainstem strokes, always look towards the cranial nerve. Always, 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 always. It will give you your answer like 9 times out of 10. You don't even usually have to worry about anything else, like thinking your way through anything else. And then the spinal tracts move up and down through the brainstem. Don't forget that the dorsal column and the lateral corticospinal tracts both cross in the rostral medulla. Do I keep saying rostral? It's 100% in the caudal. I said rostral this whole time. I'm really sorry, you guys. It's the caudal. It's the bottom. And you'll be able to see on histology why that happens. So if it's above the lesion, they haven't crossed yet. And if they haven't crossed yet, then you're going to get a contralateral loss of function. And if it's below the caudal medulla, then it's going to be ipsilateral. All right. This is a soapbox. I'm sorry, but learning these is not helpful. Do not flashcard these. It does not make sense to try to memorize these. You need to learn the anatomy and then figure it out in the exam. You will never, ever, 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 ever be asked for the name. I think all of these technically have names. I think Stepbook only gives like Wallenberg or Waldenstrom something syndrome, which is I think lateral medullary stroke. No, it will never be an answer. It will never be mentioned. It will always say lateral pontine, ICA obstruction, pica obstruction, medial medullary stroke. You will never have to give the actual name. It is so much more unbelievably useful to know the anatomy and be able to construct where the problem is in the pathway, either in your head or on your practice sheet, than it is to try to learn all these disorders. I promise you, if you just learn to put your finger on the problem and say, okay, here's where the injury has to be because this is ipsilateral and this is contralateral. Okay, that's a lateral medullary injury. You will never miss these questions. You will literally never miss a spinal tract question. You will never, ever miss a brainstem question. You have to be able to reconstruct these pathways from memory, which is why it's really important to have like a quick way to draw them out. All these will be free questions if you can do that. Okay, but so now back to the brainstem. Generally the midbrain, you need to know what these look like because sometimes they'll just show you cross sections and kind of ask either where, like they'll point a bunch of arrows and they'll say where's the lesion, or they will yeah, they'll usually do that, or they'll ask in one roundabout way. They're okay, so in the midbrain, the red nucleus is very important because the red nucleus is what determines between whether you have decorticate or decerebrate rigidity, which determines the degree of damage to the brainstem during closed head injuries and intracranial swelling. And we'll talk about that in a bit. The other thing to know is that the third cranial nerve nucleus is in the top of the midbrain. Well, it's really in the middle of the midbrain, but this is also this is really important. This is the dorsal side. This is the ventral side. I think they say it looks like an upside down Mickey Mouse. The reason why it's important to have that straight is because they flip it on you constantly. They will flip the cross sections of the midbrain on the exam upside down, backwards and forwards, and you be able to identify not only where you are in the level of the brain stem, but also which side's dorsal and which side's ventral. This is just a fancy name for the pyramidal tracts. The really important thing here, though, is the substantia nigra. This is where you lose the dopaminergic neurons in Parkinson's disease. They ask about this a lot. Sometimes they'll literally just show a picture of a normal one. So it'll be stained like dark, and then there'll be another one that is next to it that's like all pale, and it doesn't have the dark dopaminergic neuron stained here. And they'll basically ask you what the problem is, and it's Parkinson's disease. And again, this is what I say. This is exactly what I was talking about. So here you can see the substantia nigra is pale compared to how dark it is and streaky here. And you can see the loss of the dopaminergic neurons. And then the thing is so you have the red nucleus, right? Cranial nerve 3 dips down between the two red nuclei. That's really all you need to know about this. People talk about how this looks like upside down Mickey Mouse. I think this looks like a dude in stirrups, right? If his legs are up, right? I don't need to go any more detail than that. But that tells you that this is the dorsal side and this is the ventral side. Oh, yeah, that's fine. Yeah, because it's right here. Okay, so this is the so you have the rubrospinal tract, right, with the red nucleus. So basically this is a regulatory nuclei that works in conjunction with the cerebellum to like correct ataxia and control gait and stuff. If you have an injury to the brainstem and it is above the red nucleus, so it's up here, you have decorticate, right? So it's above, your arms point upwards to the cortex. If it gets worse, right? If it's below the red nucleus, you have decerebrate, so your arms point straight down. The way that they will ask this question will usually be like a person has a closed head injury and they're demonstrating decorticate rigidity, and it'll be like, which of these will be a poor prognostic factor? And like, it'll be like development of decerebrate rigidity or something along those lines. Because basically what that means is that the intracranial pressure has pushed the brain down, right? We talked about uncle herniations on Tuesday. And now you're compressing not only the midbrain, but you're probably compressing like the pons and the medulla as well, because the lesion is moving downwards. So it's a worse sitting prognosis. So if you go from decorticate to decerebrate, it's a bad prognosis. If you go to decerebrate to decorticate, it's an improved prognosis. Right, so this is what I was talking about, the midbrain syndromes. It doesn't make sense for you to sit down and just memorize these, right? Because so you know where all these nerves are, right? You can place all these nerves. So it absolutely makes no sense at all to sit here and run through these, right? The tracts follow the same logic that the cranial nerves do, where your motor function is like middle, and your sensory function is the edges. And you can see that here, right? So I don't know how else to explain. You just use it as like a guideline, right? That anything in the middle is going to be motor, and anything on the sides is going to be sensory. Actually, there's a really good slide. I don't know if I put it in here. I must not have. Where it kind of shows it. But that is just like something you should follow. Is that generally your sensory is going to be on the edge, and your motor function is going to be in the middle. The other thing to note is, you know what Horner syndrome is, right? You talk about Horner syndrome, usually in the case of like a Pancoast tumor, because those nerves dip down in the spinal cord before coming back up. You can also get Horner syndrome. You can also get Horner syndrome because of brainstem injuries. I don't really want to like talk about this because like I feel like it's just beating it to death with you guys. But if you compare these slides to basically where the nerves are in the lesions, you'll see every single one of these matches up with things you already know. So then you go to the pons. I'm gonna try to, I guess, speed through this a little bit more because I'm sure you guys are getting a little fatigued. The pons, a big thing to know is you have the fourth ventricle is here, right? So if you have like a pontine lesion, it can block the fourth ventricle and then you can get hydrocephalus. The locus coeruleus is located in the pons, right? This is part of your part of those reward pathways that you guys will learn about. And then you have, again, like I said, you have the corticospinal and the cortical bulbar tracts, right? So corticospinal, it's going down, right? This is your motor tract, it's in the middle. Anytime they ask about a pontine injury, it's going to be this. It's called locked-in syndrome, right? You get osmotic. Why is cranial nerve 7 affected in medial midbrain syndrome? Oh shoot! What did I just do? That's really annoying. Yeah, you're right. You would think, but this is why it's not okay. So it's because I need a picture. I need a picture. I need a picture. I need a picture. Okay. I don't know if I can show this. I don't want to like go off on a tangent here. Can I finish explaining and then I'll explain this to you later, where I can find the picture that I need to show it to you. And I guess I can explain to everybody, but I feel like because we're already at 2 hours, I don't want people to leave before they before we get to like what I think is like the really important thing, right? But this kind of actually comes up, you'll see actually in a second. Okay, so pontine injuries, right? These are really important. Locked-in syndrome is really important. So your reticular formation is responsible for your consciousness. This is kind of the back of the brainstem by the cerebellum. So when you have a lesion in the pons itself, it usually spares this. The problem is when you have a lesion in the pons, right? Specifically, it's usually this pontine osmotic myelinosis. This is why you can't correct hyponatremia too quickly because you end up demyelinating all these cells. You destroy all of the long tracts. So what you end up with is basically complete paralysis with total awareness, which is like the locked-in syndrome. And the only thing that is spared is your vertical gaze. So these people can only communicate by like flicking their eyes up like once for yes, twice for no. It'll almost always they'll just it'll literally describe locked-in syndrome, and then you'll just have to say like, oh, it's in the pons. Or it'll describe locked-in syndrome, and then you'll have to say like osmotic demyelination or destruction of myelin or something like that. This is they ask about this so much. And again, so to kind of I think this is actually the question the one I was looking for. Okay, so the seventh cranial nerve actually loops around the dorsal part of the pons, right? And then it goes up into the brain. So when you have a I didn't think that picture was in here. So this cortical bulbar tract, right? That gets damaged in the medial midbrain, which is what the thing you asked about. It's kind of right here. So when you're basically damaging the tract that goes up into the brain. So even though the cranial nerve exits in the pons, it goes up through the midbrain, which is why you lose you get the facial paralysis. But what's important to note is if there was ever a question that talked about like median midbrain syndrome, the other symptoms they gave you would be such a dead giveaway that the cranial nerve 7 involvement wouldn't really trip you up at all. Because you can assume with basically how the whole spinal cord is laid out and basically anything in the brain, when you damage something, everything below it gets damaged, is lost as well, like in the respective sides. So if you, and it makes sense, like if you cut out or put a tumor like in the spinal cord, any of the tracks that run through that area would also be lost. So that's why you get the cranial nerve 7 involvement in in the medial midbrain syndrome, because it's just the route that the 7th cranial nerve takes up, right? But that's like a really specific exception. But here you can see again, right? We talked about pons is ICA for lateral, right? These are odd numbers, they're sensory. Medial, you have your basilar artery. Cranial nerve 6, right? That's motor. If you know what the cranial nerves do and if you know what the blood supplies do, you don't need the slide at all. You can figure it out. I guess the only thing specific is this is like corners. The Pontine's usually more associated with corners, but again, they're almost always going to be asking you about locked-in syndrome. This is kind of but again, knowing that the cranial nerve 6 comes down in this pattern. So if you have like this is why you get the medial injury, and this is also why medial injuries can affect cranial nerve 7, like you asked about. Okay, so rostral medulla, you're looking for the inferior olivary nucleus. If you see the olives, you're in the rostral medulla. Then you need to know that cranial nerve 10 comes out here. You can usually see it. And then you have cranial nerve 12, which comes out beneath the olives. And then you have your parietal tracts. So if you have a lesion that is basically below the inferior olivary nuclei, you're going to lose cranial nerve 12. And if you have a lesion above, you're at risk for losing cranial nerve 10. And here again, you can see, so you have the olives, right? And here you have the this is the caudal medulla. I know earlier I was saying it wrong, but this is where you have the decussations of your pyramidal, your dorsal column, and also your corticospinal tract. So let's say, hypothetically speaking, you have a right-sided lesion in the rostral medulla. You're going to have an ipsilateral or a contralateral loss of proprioception and motor function. But if you had so left side, right? But if you had a right-sided lesion in the caudal medulla, you would have an ipsilateral loss of proprioception and motor function because you're losing basically where it's crossing. And they ask about this for sure. You for sure need to know this. For sure makes a difference. So I'm really trying not to like flip flop these when I say it. So I'm trying to think about the things before I say them because it's really easy to just backwards it, like in my words and not in my thoughts. But yeah, so that's really the most part. The most important thing is the medullary crossing here. And then knowing that cranial nerve 12 comes down like this, cranial nerve 10 goes out like this. You also have the sensory centers. You have the solitary nucleus, which is responsible for 7, 9, and 10. They don't ever ask questions about this. And then you have the nucleus ambigua, which is just 9 and 10. Which again, this has more to do. I'm pretty sure this has more to do with like a gag reflex. Don't quote me on that. I think this is a gag reflex. But the thing you do need to know about is the area postrema. This is 100%. This is one of the vomiting centers, right? And the reason this is important is because this is how your body kind of controls nausea without anything crossing the blood-brain barrier. It's like the only place really that is outside of the blood-brain barrier that's used to control for like nausea and stuff. And then also, generally, your cardiorespiratory centers are just sprinkled about the medulla and the pons. So when you have a brainstem injury, it's ultimately damage to these areas that leads to death, like cardiopulmonary arrest and death. And again, We can go through this, but like lateral syndrome, right? Cranial nerve 5, spinal thalamic tracts, descending sympathetics, right? So your lateral injuries are going to be Horner syndrome, right? Meiosis, ptosis, anhidrosis. And then your medial, cranial nerve 12, pyramidal tracts, right? These are your more motor functions. Right, so just a quick refresher, the rules of 4, because now we're going to get into the little shortcut. Midbrain, above the midbrain, 1, 2, 3, and 4. Pons, 5, 6, 7, 8. Medulla, 9, 10, 11, 12. Midline, you have 3, 4, 6, and 12. Those are your motor functions. Technically, the only truly lateral one is the facial nerve at 7, and then everything else is sprinkled in between. But for the most part, anything that's not 3, 4, 6, and 12 can be considered a sensory nerve, or at least has sensory functions. And then don't forget that in the caudal medulla, you have the decussations for the dorsal column and the lateral corticospinal tracts, right? And this is just kind of shows that, right? So your corticospinal tract for motor function goes down, 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 crossing the caudal medulla. Same thing with your dorsal column, right? Crosses the medial lemniscus. And then you have your spinal thalamic system, which comes up from the bottom of the body, crosses about 2 vertebrae up at the anterior commissure, and then goes up. Okay, this is like a really quick thing. I know you guys haven't done this yet, but they overcomplicate this like to hell. Okay, so basically what happens is your trigeminal nerve separates into 3 nerves, right? B1, B2, B3, right? Your ophthalmic, your maxillary, and your mandibular. They come in and they meet. They come in and they meet at a trigeminal ganglion. And then from that ganglion, right, all 3 of those nerves for proprioception, touch, and pain and temperature, they come in together. All of the pain, temperature, touch, and proprioception for the mandibular comes in together. All of the pain, temperature, touch, and proprioception for the maxillary comes in together. And all the proprioception, touch, pain, temperature of the ophthalmic branch comes in together. And they all go to the trigeminal ganglion. Then they split off in order of function. So all of the trigeminal nerve pain and temperature goes from the trigeminal ganglion to the nucleus in the medulla. All of the trigeminal ganglion touch signals go to the nucleus in the pons, and all of the proprioception signals go to the nucleus in the brainstem. Now, the only exception here, the only thing that's like weird about this is proprioception does not go through the trigeminal ganglion. The primary neurons just terminate directly in the nucleus. I've never seen them ask about this. However, what they do ask about it, and what you do need to know, is that the center for proprioception is in the midbrain, the center for touch is in the pons, and the center for pain and temperature is in the medulla. And I know you haven't done this yet, but they're going to talk about it, and I'm just telling you the only thing you need to know is these 3 things right here: proprioception, touch, pain, and temperature, in that order. And this is why. You should draw this at the start of your exam. If you draw this at the start of your exam, I guarantee you will not get a question wrong. And honestly, you could probably draw this right now if I really put you to it, right? So the first thing you do is you draw the T, right? Then you're like medial and lateral, right? So this is the brainstem. We're going to ignore this half because they're mirrored, right? So we're just talking about half of one. So you draw a T, medial and lateral, right? I do DC, medial, so dorsal and corticospinal. You can do DCC if you want, it doesn't matter. I do SS, spinal thalamic and sympathetic or lateral. Then I put in 1, or then I draw the lines, right? So midbrain, pons, medulla. 1 and 2 cranial nerves are exceptions. 3, 4, 6, and 12. Those are your median ones. And then just the rest just falls sensory, right? Lateral.
Hey, is proprioception for 5 is midbrain?
Yes.
Okay, on the other picture, you've said you flipped them in your words.
Oh, sorry. What did I say? Medulla?
Yeah.
My bad. Yeah, that's just verbal dyslexia. Yeah, it's midbrain.
Oh no, it's something that I've always flipped. So I was like, shit, I have it backwards again.
No, yeah, no. It starts at the top and it works down. Proprioception, touch, pain, and temperature. Right. So once you get the nerves in, then I do proprioception, touch, pain, and temperature. And then I draw in the blood supplies last. The reason I draw in the blood supplies last is honestly I need to think about it for half a second. I'll do Ica and Pica first. And then I know that you have basilar in the pons, right? Because it's the part that comes down, right? I'll usually also have drawn the circle of Willis at this point. Right? This is your circle of Willis. Very sloppily done. I'm sure you guys can do a better job than I did. Midbrain is SCA, PCA. I've never ever seen them ask about what the blood supply to the median dorsal or midbrain is. I have no idea, to be honest with you. I mean, I could take a guess based on drawing the circle of Willis there, but I really don't know specifically what it is. I would assume it's the top of the basilar artery, if I have to take a guess. But then this is it. If you can draw this, you can answer every brainstem question they ask you. I guarantee it. I 100% guarantee it. There's no brainstem question they can ask you really that cannot be answered with just this. And you can draw this in 30 seconds. If you draw out the cranial nerves and then this and then the circle of Willis, you can answer basically every neuro question you get on maybe the tracks. If you can't in your head just know that the tracks cross at the from down to up, it crosses immediately, and from up to down, it crosses in the medulla. You can draw that if you want, but this is all you need to know, the whole thing right here. And this is why I talked about all the things that I know you guys haven't learned yet, because it's very important that you can just draw this. And if I think I have, it's basically this. I don't know. I think today Dr. Law made you guys do this, or maybe not yet, but this is just a very quick written version of this. So I highly, highly recommend you practice drawing this out. I cannot recommend enough that you practice drawing this out. Actually, let's just do it. Do I have it on here? Did I leave a blank page? I did leave a blank page. All right, sick. Let's see if I make a fool of myself. All right, so we're gonna do this. And if you want, you can do it with me. If not, that's fine. All right. So your median, the lateral, your midbrain, your pons, and medulla. In my head, nerves are purple. Don't ask me why. But 1 and 2, 3 and 4, 5. No, not 5. 6 and 12. 1, 2, 3, 4. 5, 6, 7, and 8. 9, 10, 11. 12 is in the middle. Let's not neglect our tracks up top, right? So D, C, C. That's S. We're going to do proprioception, pain and temperature. Wow, complete brain fart. This is the other one. Fine touch. Is that what this is? Someone help me out here. I think it's touch. I think this is touch. Sorry, my brain's rotting. Right? Okay. And then Ica. It's much easier, faster to draw this without a mouse, I promise. Ica pica. Anterior spinal. Basilar. PCA. SCA. And then I think this is the top of the basilar, but they're not going to ask you about this, right? I mean, going slow with a mouse, how long did that actually take to draw out, right? While verbally walking through it. You can look at this and answer every brainstem question. And if you really, and honestly, you can answer most of the spinal questions too, if you just do, if you really want to be, if you want to draw these out like, right, so this is sympathetic, right? So you have your spinal thalamic, right? So you draw the cross down here because it's in the anterior commissure, right? It's not in the brainstem. And then for these, you just draw like a little cross at the bottom, right? Because it crosses in the medulla, the caudal medulla. And then when you're looking through a question, if they're saying, oh, this person has 10th cranial nerve palsy, well, I know that I just know right away, right? Like it's here. This is where the stroke is. Look at that lateral medulla. Just done. Done with the question. All I did was read lateral 10th nerve palsy. Done. I strongly recommend you practice drawing this out. And when you're answering questions, you do so with this drawn in front of you. But when you do that, you have to make yourself the guarantee that the first thing you do on test day, every test from now on, including both forms, including both comps, including the USMLE, is draw this. And if you can do that, you can practice answering questions with this in front of you, and you will hit every single one of these. Every single one of these. And then the only thing that like you could ever really be tripped up on is once you guys get into like the cortical strokes, it gets a little more complicated. But not really, actually. The cortical strokes are honestly easier to answer, but you guys just don't know about that yet. So we can't talk about those. You don't need this to answer the cortical stroke questions. But this is like cheating, because I guarantee everybody in this call can learn to draw this in half an hour easily and quickly. And you will never, ever miss a brainstem question or a spine question as long as you have this in front of you. All right. I know you guys are probably cooked. So tomorrow, if you want, we can do another session and we can go through tract lesions and practice questions. Or we can do some now, or we can do some psych and I have the practice questions that I have are all psych and farm, like farm psych and like just depression basically and anxiety. Because they want you to know when you actually answer the like UWorld and AMBOSS questions for these kinds of strokes, you need to know all the cortical symptoms and you need to like really know the cranial nerve stuff. So it didn't seem very useful when you guys haven't done it yet technically to do that, to give you actual questions, but we can still go through the tract lesions if you want. Or we can just rip through some of these, or we can adjourn and come back tomorrow. It's up to you guys. Give me like, I just need like if 4 of you answer, I'll go with whatever the popular choice is. Tomorrow it is. Okay, cool. Does the same time work for everybody? All right, fantastic. All right, so tomorrow we'll do an impromptu thing at 7 p.m. My brain is fried. Today's been a very long day for me, so it's probably good that we're doing this. I hope I didn't verbal dyslexia too many things for you guys. Do you guys think that you can draw this right now? If you can draw this, you're not missing any of these questions. Fantastic. Okay, cool. So tomorrow then, at 7 o'clock, we'll start off. We'll do some spinal tract questions. And then we'll do yep, that's true. 8 is the only full sensory one. That is a true fact.
Jonathan.
Well, actually, okay, except for 1 and 2. 1 and 2 are also sensory. Yeah, I'll record tomorrow's session also. I'll try to record them all. I just don't know how to post them because 2.5 hour recordings are kind of long. I don't know if you can even send them in an email, to be honest with you. But we'll see. I don't know how Teams does it. Maybe Teams just saves it, actually. You guys can just have access to it since you were here.
Hey, Jonathan.
Yes.
Do you have a mnemonic or a way to draw that circle of Willis, or it was just from repetition drawing it after drawing it? Like, do you have a mnemonic way to do it, or just I need to do it?
Heather, I do. I got you.
You do? Okay, perfect. Thank you, Alex.
I'll text you.
I will say though, for the circle of Willis,
Yeah.
Yeah, there is a Dirty Med video. However, they're just the names of where they are, like anterior communicating, or like you have your anterior cerebral and then the anterior communicating because it connects the anterior cerebrals, right?
Yeah.
And then you have your middle cerebral, and then the
Okay.
internal carotid's always drawn going inwards, right? It's internal. Then you have, pica, or I'm sorry, a posterior cerebral because it's in the back. Because if you think of the circle of Willis, like right how it's shaped, right? Like they're in order. Like it literally just describes where they are.
Okay, I'm
Like,
overthinking it.
Yeah. You'll see. There's here. I'll send you a picture of the one that I just had a blank version of it, and I just kept writing on the names myself. I just did it repetition based. If someone's got a mnemonic, that's great. But it really is. There's not a single. If you label it from top to bottom, it just goes in like verbal order of where they should be.
Okay. All right, I'm gonna have that down packed. and my little cheat sheet for the midbrain pons and medulla. So
Yeah,
I appreciate that. Yeah.
Know how to do that. No, this is so useful. This will get you so many questions. It's so much easier to answer these with this in front of you. Like, and as long as you can earnestly draw it yourself in like 2 or 3 minutes,
Okay.
it shouldn't take that long. You will have this on test day, and it will just make everything so easy for you.
Perfect. Was there anything else that you said that I need to like start drawing other than this and the circle of Willis? Was there something else?
You need to know this whole picture, but you really don't, because if you can draw the circle of Willis, the cranial nerves are all in order of exactly where you would think they should be.
Yeah.
And
Okay.
the only reason you really need to know these is because right here, cranial nerve 3 slips out between the superior cerebral and the posterior cerebral artery. And also the internal carotid kind of dips around them. So these are the common sites for berry aneurysms, and it's common to get like cranial nerve 3 impingement. So the only reason you need to know like in relation for these for each other is when you have like the ones that slip out between the blood supplies here, and then knowing like if you have an aneurysm, which nerve it's going to impinge on. Because I've seen questions like that before, and they will also literally just flip the brain over and give you someone's symptoms, and it's like really obvious, like okay, this is fourth nerve like palsy. And they're like, which nerve is it? And you have to pick the arrow that's pointing at cranial nerve 4.
Okay.
But again, it goes 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, or I'm sorry, 11, 12, right? So you're not going to get any of those. You'll never get those wrong, especially because it still follows the order of the reason I draw 1 and 2 in the middle on the top of the thing is because they do technically come out in the middle, but then 3 is in the middle, right? Like it's right there, like 3's in the middle.
Yep.
And 4 is a little off to the side, but it's more in the middle, like because you got to think that the midbrain extends pretty far up here. So and then 12, of course, right? 12 is in the middle. And then year 6, right? Just smack dead at the center.
Yeah, and they're part of that mnemonic of the 3, 4, 6, 12. Yeah.
Yep.
Okay.
Yep. All factors of 12.
Perfect. Thank you so much. I'll see you tomorrow.
Of course. I hope I didn't confuse anybody. I hope it was helpful. I'll see you guys tomorrow.
Thank you.